good evening to all, and with permission of Dr. Neeraj sir, we'll start this webinar. He's the main mentor of this webinar. So we've chosen the topic for this month as Green ICU because obviously sustainability is and living in the less carbon footprint is very, very important. And I'll switch on my camera. So, and as Sir pointed out very rightly, that cost effectiveness is a very important part for a country like us. So, just for the students and for everybody, all the attendees, and for us also, we'll be discussing about the core concepts in the first lecture. So, for that, I would like to invite Dr. K.N. Ramesh, that he'll be talking about, he's the head of critical care in Continental Hospital, Hyderabad. And as we all are aware that he's been working on this concept for quite some time. So I'd like to ask him to come and share some perspective regarding this topic, the Indian perspectives. So Dr. Ken Ramesh, please kindly share your views on this.
Thank you, Neeraj sir. Thank you, Ritu and Dipanjan sir, for giving me this opportunity. I will just open my screen. So let us discuss about green and sustainable ICU. What is green ICU? It is a greater environmental sustainability in ICU. So basically, we'll be going through what is the impact of healthcare related greenhouse gas effect and on the environment, and then on our generation and on the next generation's health related consequences, and what is carbon footprint, how to reduce that, and what are the various associations, guidelines, and the processes what they followed. How can we make some changes in India? So let us go through that. So what are the impact on environment? We all know greenhouse gas effect has various impacts on environment, like the global surface temperature has increased. We'll discuss that in detail. And then the surface ground water level also has increased, and it has led to various natural calamities like hurricanes, typhoons, various typhoons, as you can see on the screen. And also the Arctic and Antarctic minimal sea ice content, ice extent has reduced. So the water level has increased. It has led to cyclones, soil loss, all these consequences. And so as you can see, the global surface temperature has increased to up to almost 2.32 degree Fahrenheit from last 175 years. This is the highest recorded temperature in 2024. So when we see the trace of temperature, rise in temperature from 1850 till now, in 2024, it is the highest recorded temperature. It has increased almost up to 2.3 or 1.2 degrees Celsius, 2.3 degree Fahrenheit. So highest recorded surface, global surface temperature. So what are the various sources of carbon footprint or carbon dioxide emission? It can be from various power resource production or manufacturing units, or from the vehicles what we use, and various manufacturing and the transportation what we use, and fossil fuels what we regularly use, and then the plastic without recycling. So when we use fossil fuels for generation of electricity, so all these are the sources. Obviously, the healthcare system, I'll come to that in later. So what is the impact of this on the human health? So because of the air pollution, the number of cases of asthma, cardiovascular diseases, stroke, vector-borne diseases like malaria, dengue, hantavirus infection, chikungunya, all these have increased. And also, so because of the increase in the carbon dioxide and the stress levels and depression, psychiatric illnesses have increased, and civil conflicts have increased. Water-related diseases like cholera, cryptosporidiosis, campylobacter, leptospirosis, all these things have increased. And heat-related changes like heat exhaustion, heat stroke risk also has increased. So this is about the greenhouse gas emissions, and then about the plastic, and then coming to the healthcare system, carbon dioxide emissions. So plastic, as you all know, almost it contributes to 40% of the medical devices manufactured in US. But actually the countries which are affected is the mid and low income countries, which are the production unit countries where the manufacturing units are there, including India. So that's where it is more than production. How you maintain how we will manage and how will you recycle the plastic is more important. When we compare with other countries, as it is shown in this figure, India, the percentage of plastic which is mismanaged or uncollected litter is more compared to European and American countries, and the percentage of recycled plastic is also less. As you all know, plastic has its effects on environment throughout its life cycle, and almost 99% of the plastics are made from the fossil fuels, and only 9% of the plastic is recycled globally. um, so coming to Indian perspective, what are the climate changes which has happened in India because of the greenhouse gas effect and all? So when we compare the list of countries which is most affected by climate change in 2019, India stands out to be in the seventh position among the list of countries which is most affected by climate change. And when we see the extremely hot days, that is the days which have recorded the temperature of more than 35 degrees Celsius, it was around 5 per year in 2010. Now it is almost around 5. It is expected to increase to 42 per year in 2100. So expecting an increase in the death rate of almost around 10%. So coming to the air pollution contribution to our health, almost 1.6 million deaths are attributable to air pollution only, according to 2019 survey in India, almost accounting to 17.8% of the total deaths occurring in our country. So, and when it compared to when we are comparing the death per million population per year, it is around 508 in 2010. It is expected to increase 4 times to 2000 by 2060. So heat-related mortality also, when we have a survey, when we had a survey among Indian population, almost 1 in 5 people say climate change has impacted their day-to-day life. And so from 1960 to 2009, the increase of 0.5 degrees Celsius has increased the heat-related mortality by 146%. So why are we speaking about all these things when we have environmental specialists and environmental engineers and all? Because as a healthcare physicians, we are also contributing to this greenhouse gas effect. Almost 5 to 10% of the greenhouse gas emission is from the healthcare system. It depends on the country. So for example, in US, it is around 10%. Obviously, in India also, it will be around 10% only. And so in that healthcare system, when they trace down to the hotspots, almost 60% of the greenhouse gas emission is from hospitals and the pharmaceutical industries. And especially inside the hospital, when we trace the hotspots, it is from intensive care unit, operation theater, and pharmaceutical like drugs, pharmacy, and laboratory, what we regularly come across when they saw the carbon footprint from each areas of the hospital. It is expected only because in ICU, it is a resource intense area wherein each patient will be having so many machines around, ventilator, dialysis, infusion pumps, so much of equipments we use, so many diagnostic tests we order daily, and so many drugs in the drug chart. We can see a lot of like 1 or 2 pages of drugs will be there. So obviously, ICU patients are contributing 3 times more than the ward patients per day when we saw. And when they calculated per patient per day in a US study by Prasad et al. In 2022, it was around 138 kilo of kg of carbon dioxide is emitted per patient per bed. When they have compared with the day-to-day life, it is almost equal to a car driven for 1,000 kilometers. So per patient per day emission of carbon dioxide is equivalent to 1,000 kilometers of car driven. That means if you have a 100-bed ICU, it is almost equivalent to 1 lakh kilometer car driven. So that is only per patient per day carbon dioxide emission. This varies according to the countries. In Australia, it is around 88 kilos of carbon dioxide emitted per patient per day. In European countries, it is bit less. We'll see that data. So which areas of the hospital it is emitted? It is broadly classified into scope 1, scope 2, and scope 3. In scope one, it is mainly from the manufacturing units, fossil fuels which are used, and then the anesthetic gases which are produced. And second, scope two, it is from the energy like utilization from the infrastructure of the hospital, AC, air conditioning units and all. And scope three is where we are involved. That is the clinical area. That means the bedside of the patient, where we order the diagnostic tests and where we order the drugs, where we utilize so much of water, energy, all those things and all. At the bedside, we have all these equipments. Just imagine a patient at the bedside. You see all the equipments around. You have a face mask, tubings, ventilator tubings are attached to that, and the infusion pumps, infusion set, and the fluids what we use, the drugs what we use, the diagnostic test what we order for, and the vacutainer what we use for that, and the tubes and catheters what the patient uses, and the bandages and plasters what we use regularly. All these contributes to the plastic and the carbon dioxide emission. So in European data, it has shown that each per patient per day, the wastage or the mass which is excreted almost around 17 kilo, and the water usage was around 300 liters. Carbon dioxide emission was around 12 kilos to the European data. So how to prevent this, how to reduce this by inculcating various strategies is by 4 P's and 3 R's are important in greenhouse, Green ICU, that is products, processes, people, planet. In the products, we always advise to use fewer products, which is better usage of the products. Like for example, when we are using the diagnostic tests and all, advise appropriately, less diagnostic test, less interventions, less usage of the drugs. That means antibiotic stewardship will come into place, fluid stewardship will come into place, all those unnecessary. When we see the drug chart, most of the less evidence drugs will be there, which we can avoid easily. Almost 3-4 pages of the drug sheets will be full. Many things like almost 50 to 60% may not be having complete good evidence for that. So daily morning we can be seeing and checking whether what can be stopped, what can be reduced in the usage, and the processes what we follow in our guidelines. We should always keep in mind about the green aspect, reducing the number of days, evidence-based usage of the treatment, reducing the number of days of ICU, and reducing the number of tests what we advise, early detection of the disease, and then early discharge from the ICU of the patients. And the people, proper training of the healthcare professionals, and then the society is also involved in that. This we'll discuss in later. And reduce, reuse, and recycle. This also we'll discuss later on. This is a review article. So coming to ESICM green paper, these are the four main domains what they concentrated to reduce carbon dioxide footprint. That is a critical clinical area where mainly we are involved, in which we form teams. We'll discuss that team later. And then we'll try to reduce the energy usage, water usage, try to procure more of biodegradable, eco-friendly products, and then promote reusable items and recycling of the items, and reduce the medications what we use. And the domain two, wherein the research will come into place, where we do the analysis, research analysis, and find out the hotspots in the hospital, where exactly the carbon footprints are more. In that, after finding out the hotspots, we'll see the life cycle analysis, life cycle assessment of that product, how we can reduce the usage of that. And then by using smart analysis, like smart is fixation of the goals of that product. We'll discuss that in later. So this is about the research and innovation. And coming to the awareness and education, conducting various green conferences and courses related to green ICU, and certification courses, and then the guidelines, formulating the guidelines. All this will come in the awareness and education. As an association, we should have a vision, objective, strategy, and the targets to achieve the green ICU. And then with the communication with various network what we have, and each ISCCM branches, yearly targets what we can give for them, like with each product, and then conducting a model green type of conferences, and promoting tele ICUs. and various accredited, even various accreditation products are like certification also, like JCA, NABH also is having a green part in now. They're also asking for the like lead certification, and then the green ICU part of parameters are coming into place now. Likewise, ISCCM also can start some certification program like what we have for green OT and lead certification. Likewise, we can also, if suppose if the hospital is following that. So this is about the organization, and what is the pathway what we follow. First, as I discussed earlier, life cycle analysis of that product and the pathways, and then inter-organizational communication, and also convince your own hospital's management how we can reduce the cost, financial benefit we can show it to them, and then good leadership is very important for that, and then formulate a team cycle, team reduce, team rethink. So what are those themes we'll discuss in detail, and then measure the outcome with smart analysis, and all I'll explain you in detail. So what is team recycle? These are the various healthcare professionals which are involved in the team reduce and so apart from the doctors, there should be an ID nurse and a quality team. ID nurse, most of the times, whenever we are going to reduce few plastic articles around the bedside, always the fear of infection will come into as an hindrance. So involve a ID nurse whenever you're using, and involve a quality team also, because always patient safety should never be compromised with this. So that's the reason involve a quality team also along with your, and involve wherever the areas it is required, like nurses, empower the nurses, clinical pharmacists, and operations dietitians, and the housekeeping also, wherever the area they are working, and give them the proper instruction and the targets for each item what we use. For example, the gowns, we can use the cloth gloves, which can be easily washable and reusable thing, and the gloves, whenever it is possible, we can avoid unsterile gloves what we use. Gloves may not be required for touching the patient skin and all, only when we are touching the tissue fluid or the dressing or the body fluids and all, or blood collection, all those things, those times we can use the gloves, not for all the purpose. Shoe covers are not evidence-based. We can avoid that only in case of transplant patients or isolation patients we can use. And wherever it is possible, syringe, tubings, and all drugs, whichever is possible, can be reduced. That clinical pharmacy should take care of that. And pharmacy to ICU, they will come with a big covers and packages. Those plastics, whether we can reduce. What are the daily labs we can reduce? What are the radiation exposures, daily excess, is it required or not? How to reduce the power, like whenever in the night, patient also can sleep, we can switch off the lights. And whenever the desktops are not used, we can switch off the desktops and reduce the water usage. So team reduce will take care of all these things, whatever the targets we explain to them, and they will work in the ground level. Team recycle, whichever the products which can be recycled, like saline flush, nasal cannula, face mask, or IV saline bags and all, which can be recycled. There are some companies which can think of the recycling and all. And team rethink. So rethink is less drug usage with antibiotic stewardship policies and fluid stewardship policies, less investigations, less interventions. Whenever possible, we can avoid arterial line, central line, and less number of evidence-based medicine and less number of days in ICU. So all these things team rethink will come. And certification courses like Green OT certification are various contributors to climate. Like in OT, especially the global warming potential, what we see is different for various gases what they use, like volatile anesthetics and all. In that, desflurane is almost having the highest percentage of global warming potential, almost 2,500 times the carbon dioxide level. So this is about the goal what we saw in the pathway, that is smart goal component. Whenever you are giving like a smart is specific, measurable, achievable, relevant, and time bound. That means you should be very specific. For example, how many gowns you can reduce in the time bound period of 12 months, like 20% of the gowns can be reduced. Can it be measured or not? Always we can, how many gowns are indented from the pharmacy, you can always it can be easily measured. and compared after reduction and all. Whether it is achievable or not, achievable targets should only be given, and it is whether it is relevant or not. Definitely, there is a rise in the usage of the gowns, plastic gowns, and all. By using cloth gowns, we can whether we can reduce it so much of percentage target per year. So this is how the smart goal component for each team is prepared. So this is about the lead certification and the lead that is leadership in energy and environmental design. So in this, they will be concentrating on the energy consumption, energy efficiency, water consumption, water efficiency, air quality. So all these things, there are various parameters also, which they will come as a survey, like NABS survey, they will come and then they will certify the hospital as a lead certified hospital. What is SUSQ? That is Sustainability Quality Initiative Framework. So this framework will always, it also shows the reduced cost, reduced carbon footprint, add a social value, and then using the stewardship program of the treatment what we use. So mainly, basically, it will first study the root cause analysis of the secondary driver, which led to primary driver. So the primary driver is the greenhouse gas emission. In that, the secondary driver, which are the hotspots we can see by using life cycle assessment, where what is the origin, how much it is disposed, how much it is recycled, all those things and all, and finding out the hotspots, carbon hotspots, mainly in the pharma, medical equipments, acute care, and the energy. So concentrating that area with life cycle assessment and root cause analysis, and then coming up with a plan. So this is about SISQ. Finally, this is about this is the paper which shows the checklist for environmentally responsible research within the ICU. So this has redefined researchers planning, conducting, and the data processing. How to process the data? All these things are mentioned in this. So you can go through this checklist. So these are all the various association papers which are published, ASICM Green Paper, and then the ANZIC's Sustainability in ICU. So it's these are the references which we can. To conclude, we almost 22 metric tons of carbon dioxide is emitted in India every year. Almost in the government is having various projects for addressing 90% of the greenhouse gas emission in India. But healthcare system should come up with various plans, with communicating with other organizations and other associations like other specialties of the medicines and all. Government is having various like Swachh Bharat scheme and plastic regulations and rules and regulations scheme and FAME India for electric vehicles and NAPCC, that is National Action Plan for Climate Change, and solar. So these are the projects which government has, and definitely as a healthcare specialist, we also should come up with the green ICU and the green healthcare system. So with this, I think I will conclude the session.
Thank you very much, Dr. Ramesh. And it was a wonderful presentation. And I think though the ASICM is like promoting this, but don't you think that it's a U-turn? We as Indians were using green cloth, shoe covers with green. Now again, after using disposable ones, we are again coming back. We were using glass syringes initially, like 20 years back, and now we are again talking about green ICU. So I think more that will be discussed with Dr. Neeraj in the panel discussion, that I think we've taken a U-turn. So for this was the infrastructural part that Dr. Ramesh was talking about. In ICUs also we tend to do a lot of investigations. So Dr. Rupali is from laboratory medicine. She's an additional professor in SGPGI. And she'll be discussing about what is less, what is more, especially for an intensive care unit. So I invite Dr. Rupali to kindly come on this forum and throw some light on this topic, whether what is the optimal investigations for an intensive care unit? How much is more or how much is less? Dr. Rupali?
Thank you, Dr. Ritu and Dr. Neeraj, for giving me this opportunity to be part of this webinar on Green ICU. And greetings from Sanjay Gandhi Postgraduate Institute of Medical Sciences. So without further ado, we will start with the topic.
So I think we'll start with the panel discussion. Uh, for that, I would like to invite our moderator, Dr. Neeraj Tagi. He's the senior consultant there at Gangaram Hospital. And the panelists for this very pertinent topic would be Dr. Dipanjan Chatterjee from Calcutta, Dr. Shrikant from Bhubaneswar. Can I have all of them? I think
Yeah.
and Dr. Praveen from Hyderabad.
I think for all our panelists, including me as a moderator, our task has been made really, really easy. How lucid Dr. K. and Ramesh was with this presentation. But I'll start with what Dr. Ritu pointed out, that there was a time when we were using more and more of things by, if not recycling, by sterilizing them. And then came the era of infection control, and we went to disposables. So, in that light, Dr. Praveen, I would like to ask you, is it a sudden awareness about the Green ICU, the concept, and why we all are talking about it?
See, as Ramesh has spoken very elaborate about it, the temperatures have grown. It's not just that, there are other multiple hazards that have been going on. It was first time the sustainable environment, that kind of concept came 1987, long back. Brundtland report, it was a UN convention. They made certain recommendations for all how to make the environment more sustainable. For a period of time, there was a concept in 2000 which was called as One Health. One Health was not just for the humans, the plants, our environment surrounding, and the animals together. They put all this together as a single health concept, and uh, to frame any new ideas or whatever way. So whenever it's not just a human sustainability, but also the environment entire as a whole, as a whole planet together. So the next was in 2015, as you know, Paris Agreement, the Paris Convention. Even India is also signatory for it. It was a overall, in the sense, all uh, environmental sustainability ideas were flown in. There were certain recommendations made to limit the temperature growth to less than 1.5 degrees to pre-industrial level. And this India is also signatory for it, and every country who are signatory are trying their level best. In our 2017, 2021 COP25 also, there were certain guidelines that were framed, of which 7 belonged to the healthcare itself. So how to do it? So it evolved over a period of time. It was first only during 1987 it started, and slowly it has taken pace. And as of now, we are currently standing. Yeah, that's how it came up.
And I think Dr. Ramesh presented very nicely scope 1, scope 2, and scope 3,
Yeah.
the areas where the gases are generated the most. I'll go to Dr. Shrikant, and probably Dipanjan can chip in. And I like your take as well, both of you gentlemen. I mean, these are good, you can say, global practices or global goals or aims that we are talking about. Let's talk individually. Let's talk about what one can do about their own ICU. So I'll start with Dr. Srikant. I mean, what kind of goals you would like to set for your ICU, and then probably what kind of roadmap one needs to create to achieve them. So I'll start with Srikant.
Yes, good evening, sir. As Dr. Ramesh told in detail, sir, in individual ISU, we can set big kind of goals like so use of disposables. What you use disposables? Say it number of gowns, say number of gloves, say number of any kind of disposable number of injections you use. Many things are not actually necessary that we use. We can set number of the gowns we use for disposable gowns we use for the patient attendance, number of the shoe covers we use for the patient attendance during each daily visiting hours. These things we can reduce, and we can use these things judiciously. We can use when these things are really necessary. If we come to the drugs part, the many drugs, as Dr. Ramesh has highlighted appropriately, many drugs are kind of what we say the add-on drugs, not necessary drugs. We just give them some supplements, then add-ons. We can cut short these things to the necessary. And I'm not against using some multivitamins for a particular period of time, but not that just continue till the patient is on ICU. Suppose we are doing some procedure, we can limit the use of gowns. Not that every person, all the trainees, all the nursing officers are in the team to wear the gowns. I'm not against using the sterile procedure. Sterile procedure maintain the sterility, but we can just use these things judiciously. That is one. And for each procedure, for everything, for each just what for every procedure we do, every moment, every day, and for everything, if we can use these things judiciously, then we can just cut down the use of the disposables to significantly. And at the same time, we also have to keep in our mind the safety of our patients, the outcome of our patients. So it is not like we are against these things, but we have to use these things judiciously to reduce the use, so that we can achieve we can also reduce the cost. We can reduce the effect of the carbon emission or the bio waste. We can reduce, so that our patient safety will maintain, our outcome will maintain, and our cost will be reduced. At the same time, we can be the environment friendly.
So probably, if I can summarize what you are trying to interject here is, we need an attitudinal shift. Stewardship is not just about antibiotics, antifungals. Stewardship is about optimizing resources of each and every kind. We just need to look at prescription, procedures, and all in the same light. So probably the best anecdote that I can think of is also about how we need to evaluate uh, the considerations or the guidelines or whatever statements that come across us about our practices. For example, the personal protective equipment, PPEs, in COVID, when they came, we were all using it. And by the mid of second wave, NHS came out that they are not needed, and we all shifted to green gowns. Immediately, we shifted down. So probably that is also something we need to look at about all our practices. And I'll go to Dipanjan. Dipanjan, just one big dichotomy. The way I see it, maybe I am turning old and the cynicism is creeping in. We are talking about, and Ramesh was pointing out repeatedly, that we need to do remote monitoring. We need to bring somehow AI into it. But when I look at the global data, the IT industry, their contribution to greenhouse emission is much more the entire aviation industry combined over a period of 2 years. That what IT brings it. When we talk about all these AI driven platforms, be it remote monitoring, be it converting all our data into digital ways and then storing them on servers, he pointed out that the groundwater is receding, the seawater is coming up. We gonna need huge amount of cooling capacity if we're gonna store so much of data. The cloud storage is not in cloud; it's server. It's a remote server, but it's the same as Praveen was pointing out. It's the same One Health thing. So how to overcome this dichotomy? Can Dipanjan, you start with this, and then probably Praveen and Ramesh can contribute. Dipanjan, up to you.
Can I add to that?
Sure, sure. Please.
See, actually, the concept of green thing, not just the decision that you make in ICU, but it actually starts from the prevention itself. So, patient coming to an ICU can be an example. Patient with influenza and pneumonia. You have a vaccination program to many people so that many people will not be affected. ICU resource itself is not used, isn't it? We use so much in diagnosis. Example, we order the X-rays. Instead, we can use an ultrasound, isn't it? Okay, and the energy which we use, we can become renewable, like solar. We have got a good solar program running by central government right now, and we can harness all the solar and light. We have 365 days light. It's not like other countries where they have dark days. So in the morning we can use more light. More of the corporate ICUs, live ICU are completely closed. Like we can have actually the natural light coming in. So these are ways we can actually reduce. It's not just, of course, the prescription does go. It does contribute, but we can. This also actually contributes to us. So that's why I think I can add. Yeah.
Of course. So primarily the infrastructural thing and it has
Yeah,
to be a
yeah,
combined effort. Then you have societal things, the programs, preventive healthcare. It's gonna
yes,
shift in a very big way.
yes.
Ramesh, what's your take about the AI integration? How we gonna handle that? It's gonna be almost a necessity which gonna come like an onslaught to all of us. We're gonna become digital by day, if not by year. How do you see that that's gonna come in way, and how to negate that challenge?
Actually, it is an excellent point what you made, Neeraj sir. There are three components in this. One is the paperless documentation, the EMR which is used for paperless. We can avoid all the papers which is used, bundles of papers what you use. And then the production unit also will produce so much of fossil, utilize so much of trees in that. So in that way, it is helping. Second thing is remote monitoring device, and third thing is tele-ICU. So these are all the electronic equipments what we use in our day-to-day life. When we use remote monitoring device to the ward patients, our documentation. I am using that remote monitoring device in our hospital. So after using this one, we made no documentation from the nurses, zero documentation from the nurses. It is all stored as a PDF daily. Vital monitoring, everything is stored as a PDF for each patient per day, and so the paper is completely avoided. And coming back to the tele-ICU, so the patient we can treat, we can manage from the sitting from the remote place. No need of the patient transferring from one place to another patient, another. So the transportation, carbon dioxide release and all is avoided. Patient can be treated there only with the advice, with the expert advice from here. And also the cost also will be reduced to the patients attenders also. That's how I think. But definitely, what you use the server utilizes AC, air conditioning, water utilization, all those things and all. So we have to see how to conserve the energy there by using more solar panels and greener, eco-friendly energy production methods.
The one way I look at it, probably rather than uploading everything on cloud, we can have them on drives which are stored, and we can access the data as and when it is needed. Particularly when we talk about hospital record keeping sections or investigations. I mean, it's one thing is to have immediate access, that is nice, but to have entire thing accessible all the time is gonna drain us so much of energy, and the water which gonna come in terms of cooling tower. Is Dr. Dipanjan with us? Dipanjan, have you joined us?
And since we have a limit for electronic record maintenance,
Yeah.
so auto deletion, it will be automatically get deleted once it reaches like our central monitoring system will get deleted once in 48 hours. Within that, if you want to store, we can store it. After that, automatically the server will delete that data, whatever it is recorded from the patient.
Probably reducing the noise, reducing the unnecessary information storage is something we all need to look at. For example, I mean, so many of us would have at least 10,000 of the emails unread which are stored in our server individually. So these are the kind of considerations probably we need to take up from our daily life and integrate into the medical practice. Dr. Rupali, um, let me ask you one thing. Usually labs are the first one to imbibe any kind of technology which is happening. For example, as Dr. Manishetty already pointed out, we need to use more and more of ultrasonological diagnostic things in ICUs, particularly because we are all trained and we are trying to answer a particular question, not trying to diagnose something out of a black hole. So, how do you see the other lab services can contribute to reduction in the scope 2 area when we talk about?
First and foremost important thing is, I would say, is pre-analytical, is that even before the sample reaches the lab. So many times I see whenever a attendant, now many hospitals have pneumatic tube systems, but whenever the paramedical staff is holding any sample, for example, be it a vial or maybe a syringe, they wear gloves, sterile gloves. That is absolutely not required. Even if the vial contains sample of a patient who has retroviral disease or hepatitis B for that matter, the vials that we get in now, they have that protection so that the infection is not transferred. So first is the pre-analytical part, where we do not need to use this plastic apron, gloves, mask just to hold the vial or just to transport the sample. Second thing is we have this containers, vacuum containing containers. So lot of hospitals are coming with the initiative where they are recycling it after the sample is processed. So that is one initiative. And nowadays the refrigerator, the analyzers that are being indented into the hospitals, they are free of this chlorofluorocarbons. That definitely raises the cost for the purchase department, but yes, that definitely reduces the carbon emission. Yes, so that is something from the laboratory point that can be done, and that will definitely contribute to the reduction.
One more thing, please stay with me. Let's talk about diagnostic stewardship. Let's talk about where is the evidence about sending daily CBCs, RFTs, and probably electrolytes, doing blood gases on daily basis. Is there an evidence about it? We are so fixated in terms of intensivists, at least looking at these parameters and comparing them with the previous day, and then probably taking decisions based on like 1% or 2% values changing here and there. So what's your take about it?
You are actually making me say a whole of my presentation. So what repeated investigation leads to something called as alert fatigue. So whenever we are getting this investigations, it is going to give us continuous reports. Now continuous report means bombarding the clinician with this critical values time and again. So there is going to be a time when this clinician's mind is going to get clouded, and there is not going to be that response that should happen. Like we can just correlate with the story of the cry wolf, that wolf was cried out, and when actually the wolf came, everybody thought it was a false alarm. So this repeated investigations are not required, and this leads to alert fatigue. So definitely not required, and every ICU should make a policy as to how frequently the investigations are to be sent, depending on the resources they have and the population or the diseases that they cater to. So accordingly, that policy can be made and investigations can be sent according, not just as part of the protocol.
Dipanjan, thanks for joining. What have you been practicing regarding all these? One would be reducing the number of disposables that one can or one should rather use. And second, the most important aspect is I'm turning really critical of sending these daily investigations. So, what's your take about it? How you are practicing these things in your daily life?
Yeah, we see patients mostly in my practice. If I take the patients who are on ECMO, venovenous ECMO, they are in the ICU for maybe months or more than a month together. There, the initial 1 or 2 days, maybe intensive seeking out the cause is there. But after that, we have to come down on the number of investigations. Otherwise, both it is unnecessary to do 4 ABGs a day. It's only 2 or even 1 ABG a day will be enough. Secondly, the other investigation needs to be curtailed. So, and daily X-rays not needed at all. An alternate day or thrice a week will be good enough, because unless we curtail the number of investigations, we are increasing the energy cost, we are increasing the cost to the hospital and also the cost to the patient's relatives. So the net cost to the patient goes up significantly. So that has to be taken into consideration. Do only those investigations which are absolutely necessary. Ask yourself whether this investigation is going to change my practice or my treatment in any way. If what is the results, then we can do it. Otherwise, there is no need of surveillance cultures every 4th or 5th day for these patients. Only if the patient is showing some infective change, then only send the investigations. All these things we need to keep in mind.
Great. I mean, because probably that also answers our about question in part when we talk
Can
about the
I add
economics of running
something?
an ICU. So I can take an example, an anecdote, and probably then Dr. Ramesh and then Vinish Shetty, both of you can give your opinion about it. Let's take an example of a patient who has come from community with a community acquired infection. We have a 24-hour trend with us about this patient. Rather than having this habit of sending investigations 5 a.m. in the morning, is it possible to have a look at the patient, the morning round, and then probably decide today these are the numbers we would like to see? At 24 hours, this nothing's gonna change in a stable patient. If my patient is probably dropping on urinary output, there is no point looking at the TLC. All I'm concerned about is serum creatinine. Is this kind of paradigm shift in how we round our ICUs, how we decide our day and everything possible and doable?
Yes, sir. Yes, sir. And the shift actually I wanted to add just previously, but the thing there is one paper in BMJ where they pointed out how low income countries are maintaining their ICUs. It is out of because of obligation and resource limiting which they are doing, like uh, line and which I use, we keep autoclaving them and using it again, like that kind of stuff. So similarly, I have actually trained in Apollo Chennai, and I am currently practicing in a tier 3, tier 4 kind of area. So here financials are always constrained. So people would say one innovation written that 500 rupees also is cost to that patient. So initially when I came to practice here, it was quite hard for me, but over a period of time I adopted to this. In fact, I'm actually doing it. In fact, I wouldn't even write a CVP throughout. I mean, probably until the patient gets. I only see clinically, in fact, daily. Only if some patient with dengue with severe pancytopenia or cytopenia or whatever. That's the only way I see. If the trend is increasing, like today I ordered and tomorrow it's increasing, then I would wait for 1 or 2 days. There is no hemorrhagic signs. What I'm going to do with no hemorrhage at all? No, isn't it? So that's how I do. I am actually doing it. In fact, ABJ I put a CO2 in hypercapnia, I put in an IV, it's improving and patient is conscious. That's fine. I'll do it. So that's how I'm doing. I'm actually doing it. I've learned it. I would say probably our intensivists need to be trained in a lower resource setting also. That's what I think. That's rather than saying and just putting a team. I would think when you come down, then you would get actually know. I wasn't doing it before, but I'm doing it now. Yeah, I was.
Just
Yeah,
suddenly I'm turning more and more orthodox. So I avoid using resource limited. I said probably we are the ones who are utilizing the resources more optimally.
yeah,
uh, Everything has to be recycled, everything has to be looked into whether it needs to be used. So Ramesh, then Rupali,
Yeah.
Shrikant, and Dipanjan. Probably
Yeah.
Dr. Rupali would be ready with her presentation. So let's have one final comment from each of you. How you see, for example, this one practice is starting the round and then deciding what investigations.
Mm.
And Benny Shetty already said, let's use more and more of ultrasound and reduce any kind of radiological exposure otherwise. So give us samples, each of you, and then we can go to Dr. Rupali's presentation.
Probably what you told is correct only. Minimalistic investigation in the morning, and then after that, the issue-based investigations. Like if the patient has melena, then a hemoglobin as a target wise. If the patient is having bleeding, iron or a platelet count, where an intervention is required or a transfusion is required. Or if the patient, you gave the example of dialysis or reduced urine output, an ABG, a potassium level, and a serum creatine, that is enough. So like that, like issue-based investigations after the round, I think we can always advise. And coming back to the role of ultrasound, there are many papers that ultrasound is almost replacing the X-ray, daily X-rays especially. And we can find out the collapse, we can find out the consultations, and we can see the effusions. No need of doing a daily X-ray to see the same finding again and again. And ultrasound, in fact, is utilizing less energy, less radiotoxic, and no need of shifting the patient to the radiology department. Wherein the MRI and the CT scan machines will utilize so much of energy. Energy utilization is more in that. Only when the intervention is required. For example, for a trauma patient, we already know the abdominal with the fast scan and all, there is a bleeding or blood collection in the abdomen. So to know the focus of bleeding, probably an angiogram is required. So like that, based on the ultrasound finding, we can advise for a CT scan, or if it is not there, not required. For all the trauma patients, getting a CT polytrauma protocol from head to toe may not be required. So like that, those type of things, utilization of more ultrasound, what we have as a tool at the bedside in all the ICUs, I think nowadays, so that is having a major role. That's what I feel. And most of the interventions which was done previously by CT guided, now everything is done under ultrasound guided only. So I
Great.
think.
Srikanth, your thoughts about it?
Yes, sir. Sir, as per the X-rays concern, the routine X-ray are not required. We can do only one best demand basis. That is one. Second, regarding the investigation, once the patient is stabilized, suppose as you are saying regarding TLC, suppose we have started on, we got some TLC report, and the patient has started on antibiotics. We don't expect the TLC will fall by 24 hours or 12 hours. Will take 40 days or 72 hours. So there is no need to repeat CBC or TLC after 12 hours, 24 hours. We can decide the clinically, suppose patient is worsening clinically, till the patient TLC is coming down. We are not going to stop the antibiotic or de-escalate the antibiotics. We have to wait. So these things, just not only radiological investigation, also the hematological or blood investigation to be done as on the demand basis, as and when required, and depending on the clinical assessment of the physician. That is one, sir. Second thing, regarding the greenhouse issue, in every moment, in every single possible the procedure or the things we do or every patient rounds, in every moment, whatever we do in the rounds, of the rounds, on the rounds, we, so this is basically mindset. We have to keep in mind that whatever things in each moment, each day, each activity we're doing, what can we reduce, but not at the safety of the patient or the outcome of the patient. Keeping the safety and the outcome of the patient in mind, and what are the minimum things we can do to maintain what we say, the less is more. That's what I can say.
Great. I think I'll come to the Banjan. ECMO patient is somebody who needs maximum amount of resources, and even pandemics they teach us something. For example, at the peak of pandemic when we were all struggling for oxygen, there was lots and lots of debate how we need to relook at high flow oxygen therapy. So, what are the areas you think we need to relook in terms of evidence base, in terms of resource utilization when we talk about such patients?
Most of our patients, ECMO patient is just a patient of critical care. We shouldn't be thinking about the ECMO patient. And patient who needs a lot of attention by the physicians, nurses, and technicians. That's the most important thing. And the machine needs to be running. If you remove the ECMO machine, even a critically ill patient in the ICU needs such amount of our attention to maintain the patient. But the resources that we are utilizing for them, those resources can be rationalized a little bit. As I told previously about the diagnostic stewardship front that we have to look into, the stewardship for the antibiotics. We are going on giving antibiotics in without a culture proven diagnosis. Most of us are afraid to run a ECMO without an antibiotic. So we are we unnecessarily giving medications which can be easily curtailed. And once we start a medication, we don't see that we have to stop them after a certain period of time. Many a times, if the number of teams seeing the patient increases, if the number of people seeing the patient increases, unless it is a single person leadership who is taking into consideration everything of the patient, many a times we find that duplication of medications in the medicine card. All those things can easily be stopped if one team or one person is very vigilant about what the patient is getting every day during the rounds, taking care that the medication chart is perfect or not, if anything can be reduced. Always the thought that we have to reduce the medications. We have to reduce the investigations should be there. It's just like running a we have in our home. We see the mother taking care of each and everything of the house, that she will not allow us to waste. That mentality, if we can carry forward in the ICU, then only we can have a green ICU where the energy is everything, including the energy, has to be perfect according to our needs. We have everything, and if we have everything, if we have, do we have to use everything? We don't need the monitors which are not being needed for the patient to be on 24 into 7. We don't need the oxygen and vacuum to be on every time. We only in the ICU, whenever you go in, you will see that many of the patients where they are not needing an oxygen, the oxygen is still on. We can come down on them. All these things we need to take care.
Great, Dipanjan. I think we all need to be as courageous and as frugal as a Bengali mother. Probably that's the best way I can put it.
Yes.
Venish, your last comments, and then Dr. Rupali, the most important one has to come from you. How to have the synergy between the intensivist and the lab person? But Venish, you close it, and then we'll go to Dr. Rupali.
I think the message I would like to give is communication, two-way communication between the laboratory and the intensivist. Because many a times it is just one way. The sample is sent, and that is the end of story. Only the report is viewed. Like, let me give you an example. In a patient of thrombocytopenia, we need to monitor for the platelet count. So the request that we send is just the platelet count. But with the technological advances, whenever we process the sample for the platelet count, we do get indices which tell us whether the bone marrow is responding or not, like platelet to crit, then immature platelet fractions. Now, these reports are many times not uploaded onto the patient's report. So, if there is a communication, maybe this information will come across to the intensivist, and the number of requests that are sent will definitely come down. So I think two-way communication is the way forward.
Dr. Raveen, your closing comment.
Almost everyone has spoken elaborately and not left nothing to me to speak on. But all this put together, it needs to be a teamwork overall. I think the green team is a way forward. You can form a green team, which would include a physician, in charge nurse, and the technician in the ICUs together, and each of them would monitor themselves. You train the in charge person, and he would take care of the rest. So you would be the head person, and the rest of them will be taken care of. If once these things streamline, the next generation, whoever replaces them, will be continuing it. So I think the team and vigilance is more important. What all we say might not be executed all the time. So we need to see is execution part. Execution by team would be better. That's what I think.
Great. So probably what we need to do is have an attitude of stewardship about each and every aspect of ICU care. What we need to do, we need to look at all the algorithms, decision-making trees, and our daily practices from the lens of turning them into carbon and heat neutral. And I think the next generation is far more aware, so I'm much more hopeful that they will be more forthcoming. So thank you all my panelists for making it such a dry topic so lively and giving real snippets which are practical and should be used and can be used in our ICUs. Over to you, Dr. Ritu.
Thank you, sir, and thank you to all the panelists. Yes, it was very vibrant discussion. I think code green or green should be the theme for us, all of us next year. So without wasting much of time, I think I'll ask Dr. Pali. She's already shared the presentation. So to start with how to rationalize the investigations, and then we'll end this year with this green ICU concept, something to ponder on. I said, I think, sir, we all have a learning curve in this green ICU. So we probably learn in this.
We learned, at least I learned a lot today.
Yes, sure.
Okay, so how much time do I have?
10 to 12 minutes, Rupali.
Okay, that should be good. Okay, thank you for the opportunity, and I will just start with the presentation. Yes, so the patients in the ICU, as we all discussed, they are critical and require close attention. So the investigations are to be sent, and we send the investigation in the form of various blood, tissue, and this is sent so that we have a time to time exact evaluation of what is happening inside the patient's body. Now, since the admission of the patient, we do the investigations to do the diagnosis, then followed by monitoring. But in addition to this, nowadays we are having this defensive medicine. So let me discuss more. With the now, what is defensive medicine? Defensive medicine is wherein we send investigations that are actually not contributing to the patient's management, but they are sent. So the question arises, why are they sent? They are sent because we have implementation of this Consumer Protection Act. Then a lot of times the money for the patient's bill is paid from the insurance claims. And also with the wide use of this internet, we have the patient's relative asking us, was this investigation sent, or was this intervention done? So that is why the number of investigations sent is being increased. Now, when we draw a sample from the patient, the first option is to send the sample to the laboratory, which is the hardcore establishment for processing the samples. But with the technological advancements, we do have the option of doing the investigations right in the premises of the intensive care unit by point of care test. Now, this point of care test, they have the advantage that minimal amount of sample is required for the test, and we do not require a trained laboratory technician or a pathologist for the report. And the best part is that the report is available within a short period of time. But it also does have a limitation that the results are not very much reliable. They just buy us time, or they just give you a scenario where we can tide over the acute crisis. However, the result needs to go to the laboratory for the final confirmation. And yes, as we already discussed, the burden is really high for the investigation sent for testing. Now, if you look at the tests that are being sent, ABG tops the list, and followed by this, we have the hematology, coagulation, biochemistry, and culture sensitivity samples. These are most commonly sent. Now, once we send in the sample for the patient and we diagnose, we do some intervention, or many times there is a onset or the event like organ dysfunction. So doing the investigation once is not possible. We need to go and evaluate the patient time and again. That means we have to keep on drawing the sample. And study has shown that the sampling was done more when the patients were admitted during the night shift, or the patient was a surgical patient, and the treating doctor was a junior doctor who sent in more investigations because he was not able to figure out what was wrong in the patient, and that led to more investigations being sent. And as we all know, ICU patients have a central line, making it easy for the sample to be drawn. And it is also seen that ICUs, which are attached to teaching hospitals, there more investigations are sent as compared to ICUs in a non-teaching hospital. When we talk about overuse of lab testing, there is definitely some local tissue injury. And because of the central line in place, whenever the sample is being sent, a 10 ml of discard tube is required to be drawn first before the sample is sent. And many times, if this is not done properly, it is to be actually discarded. And literature says that patients in ICU require transfusion because of frequent phlebotomy. Now, the cost of ICU treatment is anyways high as compared to the ward, and this laboratory testing is going to increase the overall cost. And more number of investigations going to the lab, more time it is going to take to report. Now, in the ICU, usually we have a nurse looking after 2 patients. Now, suppose a sample is to be taken for 1 patient, the sister is going to give the charge of the other patient to an alternate nurse. Now, alternate nurse might not be very much updated regarding the patient status, and any subtle changes in the patient might be missed. So the other side of the coin is underuse of laboratory testing. Suppose we decide that yes, there is overviews, we will not send many investigations. Now, if we do that, there is going to be a delay, and maybe the patient goes on to have irreversible damage and this loss of chance. So that brings us to the burning question, how to do it rationally. So let us walk the path of this rational use and see what all options do we have. So about a decade ago, there were guidelines set up by this Critical Care Societies Collaborative. However, even after a decade, the result that was expected has not been achieved. So let us see what we can do by just implementing some simple things. Clinical indication, like my colleagues already pointed out to that. If it is required, then only we will do. Then many times when the investigation has been raised, the clinician is not aware of the cost. So it will be nice if we can just display the cost of the investigation somewhere in the entrance of the ICU, or whenever a new doctor or a staff is posted in the ICU, during their orientation program, if they are made aware of the cost of the test, so that the costly tests are not repeatedly requested. And while ordering a test, the risk, the procedural risk in obtaining the sample, is it going to outweigh the benefit? That should be taken into consideration before ordering the sample. And now management of patient in ICU is a team effort, the doctor, the junior doctors, and the paramedic staff. Let me give an example. Like, for example, albumin. The half-life of albumin is 20 days. So there is no point in sending albumin every second or third day, unless and until the patient has undergone some change or it is expected to decrease or increase. Then only it should be sent. So this information is going to help while raising the test. And of course, point of care devices are going to give the result quickly. Now, other option is audit. Now, when we talk about audit, the thing that comes to mind is lot of paperwork and involving complex statistics. Actually, that is the right way to do it, but we do have simpler ways. Suppose we have a patient who has stayed in for hospitalized for 10 days, and his hemoglobin during his hospital days was sent for 10 times. So the hemoglobin test index will be 10 hemoglobins on 10 days, that is 1 hemoglobin per day. So when the patient is discharged, we can see that this 1 hemoglobin that was requested every day, did it actually make a difference? Was it actually required? Then other thing that can be checked is, did the patient require blood transfusion even though he was not having any massive bleed or did not undergo any surgical interventions? Then other things like CLABSI rate and how many times stat request was sent for any laboratory investigation. Now, panels are tests which has more than one test. Like, and these panels commonly that we order is complete blood count, liver function test, kidney function test. Now, these tests, if like for example in kidney, even if we can just do with creatinine, why go for the whole panel? And one of the panel things with panel is, like for example in renal function test, I might have uric acid in my panel, however my colleague not might have. So it varies. So accordingly, whatever test is required, that is to be sent. Every ICU should have a policy depending on the resources, the funds, and the patients they cater to. And it is equally important to keep on updating this policy. But the most important or difficult part is to adhere to this policy. Now, many times it happens that an investigation is sent, and maybe it is sent in the morning, like ICU, 6 a.m. They send samples, and in the late evening, when the report does not come, a call is sent to the lab that we did not get the report, and the lab says they send a fresh sample. So, let me just give this example. A patient is suspected to have central line associated bloodstream infection. So, when the form requisition has been sent, it is important that the details of the antibiotic, history of fever, many times it is just entered as dash dash. That is not to be done. It is going to blind the microbiologist while setting up the sensitivity panel. And when the sample is sent, it has to be sent properly. Like in this case, it will be the catheter tip along with the peripheral blood. Now, this peripheral blood has to be sent in the proper amount. Like usually it is 5 ml in case of children and 10 ml in the adult. And this quantity is going to decide the chances of having a good yield. And the number of files, aerobic, anaerobic, that also needs to be sent. Now, many a times it is seen that sample is taken at night time or when the laboratory is closed. So the sample is not to be stored in the refrigerator. It is to be stored at room temperature. And if the institute has pneumatic tube system, then ideally it should not be sent through the pneumatic tube system. Why? Because this is going to decrease the chances of having any yield in the sample. And of course, we know it is going to take at least 2 to 3 days for the culture report to come. So it is always nice to have an institute antimicrobial susceptibility policy. Most of the institutes have electronic way of generation. So here we see that in case hemoglobin is already raised for the patient for that day, when we raise it again, the electronic system is going to give us an alarm. Is it actually required for the patient? And yes, two-way communication, very much important. So that will help. Maybe the sample that has been received in the laboratory, we want to add a new test, it can be processed on the new test, or they can suggest any other parameter they have which will help with the patient management. So this is my take home message. Whenever we want to set a investigation for a patient, it will be nice to have these questions answered before we send in the request. And thank you for your time and patient listening, and wish you a Merry Christmas and a happy and prosperous New Year. Thank you.
Thank you, Dr. Rupali. And before I say Happy New Year, we all must thank Dr. Ritu. She's the one who tirelessly works behind the scenes. I mean, discussing regarding what topic to pick up, which speakers, and then she coordinates with all of you from designing the flyer to dissemination of then when the event is about to happen, and knocking each one of us out of our somberness before 7 o'clock to join the panel. So thank you, Ritu, a lot for choosing such nice panelists, nice topics, and for all the hard work that you have been doing. Thank you, all the panelists, and of course the attendees. May all of you have a very great new year. I thoroughly have been enjoying, and probably next month we're gonna come up with something more exciting for all of you. Thank you so much.
Thank you, sir.
Thank
And
you,
I
sir.
think I'll not be wasting much of time. We are already over time. So a happy new year to all of you. And it was a great learning for all of us because the topic was really different. And just that, we'll end this. And thank you and happy new year in advance.
Thank
It
you.
was
Thank you. And thank you.
Bye.